This session's topic is asthma. And at the end of the session, attendees will be able to, one, review the diagnosis of asthma, two, discuss the different types of asthma, three, discuss the differential diagnosis of asthma with case presentations, and four, learn the current treatment guidelines for asthma. We would like to thank our sponsors for today's webinar, AstraZeneca and Pharma. Our speaker for this session is also a product of the UP College of Medicine and a proud member of my class, 1990. She then earned her master's degree in public health at Johns Hopkins University, Bloomberg, and she did her postgraduate training at various hospitals in the United States. She's part of professional organizations such as the American Academy of Pediatrics, American Academy of Allergy, Asthma and Immunology, and the Philippine Society of Allergy, Asthma and Immunology. She also has several awards under her belt, one of which is Hampton's Roads Top Doctors of 2011. At present, Dr. Tomesis is working at St. Luke's Medical Center. Without further ado, let's welcome our speaker, Dr. Grace.
Good afternoon. Thank you, Dr. Quintos and Dr. Genuino for inviting me to be part of the UPMAS webinar series. When Genuino asked me to present this as part of our final talk for the webinar series, I was in panic because asthma is such a huge topic, and I think by the time I was able to make my slides, I had changed the learning objective to something more manageable and more concise. So I'll present a different set of learning objectives as we go along. And welcome to our reactor, Dr. Francis Dairit, who is joining us from the great state of South Carolina. These are my declaration of conflicts. None of this, however, will affect the content of my talk today, both talks today. These are my learning objectives. Since asthma is such a broad topic, I thought I would narrow it down for today's conversation to the meat or the Bible of asthma diagnosis and management. It's an 800-page mammoth document that has been published 3 times by the National Heart, Blood, and Lung Institute of the NIH. And its 3rd version came out in 2007. There's a current proposal by the expert panel to provide new updates as new data and evidence has been published over the last 8 years. So a third part of my learning objectives would be to present the 6 updates proposed by the National Asthma Expert Panel that would be included in the next version. And I will discuss in further detail 4 out of those 6. And lastly, I have a link that will be available to all our participants, reviewing the proper use of spacer device. First, I'd like to present a comparison of prevalence data between the U.S. and the Philippines. The World Allergy Organization has published what we call the White Book in 2013. They rang like this alarm bell that all types of allergic diseases have been increasing worldwide. Doctors Verona, Dr. Kwong of the Philippine Society of Allergy, Asthma and Immunology, in 2014 published the results of the National Nutrition and Health Survey. And it describes the prevalence of asthma among Filipino adults. And to date, it's one of the biggest surveys, and they used the ISAC survey tool, which is the International Study of Asthma and Allergy in Childhood, and questioning Filipino adults 20 and older using the parameter of wheezing in the last 12 months. The overall prevalence is 8.7%. Interestingly, the prevalence rates in men is higher than women, and you'll see later that this is reversed compared to the U.S. data. Now, when the ISAC survey uses question of ever wheeze or lifetime wheezing, the prevalence rates increased to 14.3% compared to 8.7%. So you can see from this percentage rates that there's a huge burden of disease for Filipinos. The childhood prevalence studies have been published in the past, but most of these surveys were focused on Metro Manila. The most recent childhood prevalence study was published in 2003, and there has been a huge range reported by these studies, and it goes anywhere from 9.2% to 27.4%. I just made this bar graph just to show you the comparisons between childhood asthma, and this set of graphs will be adult asthma, and the blue bar is showing the results for wheezing the last 12 months among males, and wheezing, and this mint green bar is wheezing in the last 12 months for adult female Filipinos. And this is the ever wheeze question, which is a lot higher than the prevalence that we discussed earlier. So I've included the link to the journal that was published for the Philippine data for your information and reference. Okay, meanwhile, the Center for Disease Control in the US in 2013 published the data of the US overall prevalence, which is 7.3%. And the breakdown for children below 18 shows the preponderance of asthma among males. However, this rate is reversed as the children are surveyed beyond 18 years of age and into adulthood. That prevalence rate reverses, and more females are affected with asthma by the time they enter late adolescence and late adulthood. Now, this is just a summary of that slide that shows the male predominance in terms of prevalence, and male children actually catch up, female children catch up with the males between the 15 to 17 age group. And that trend continues, a reverse trend continues as you survey more adults up to age 65. So this is the difference between the prevalence rates between the US and the Philippines. More females are affected with asthma in the US compared to Filipino adults. And I wonder why, and I defer the answer to this question to my Filipino colleagues who may be able to enlighten us at the end of this talk. Now, this is really the meat of any discussion for asthma diagnosis treatment and monitoring. It's an 800-page, the NAEPP guidelines is an 800-page document that has gone through several revisions, and the most recent one, as I said, was published in 2007, and it's the third version that has been released by the NIH or through the NHLBI. It's historically the first published guidelines were in 1991, but the formal document where it was actually called National Asthma Education and Prevention Program was brought out in 1997, and its second revision was in 2002. So the current iteration is 2007, and as you can see, there has been a burgeoning amount of scientific evidence that has been published since 2007. Now, the difference between the 2002 and 2007 version was that the expert panel, or the panel that was designated by the NIH to study or come out with the guidelines for clinicians who take care of patients with asthma, was of the 0 to 4 age group. And this is very important for me as a pediatrician because prior to the 2007 version, we would extrapolate the data or the management approach from the age 5 to 11-year-old recommendations. So this is a very important difference that came out in 2007, especially because a lot of pediatricians or a lot of family physicians refuse to label toddlers and kids younger than 4 with asthma. So now there's guidelines that backs up our clinical suspicion and clinical diagnosis. The other main difference is that the expert panel has put very pragmatic guidelines in terms of diagnosis of severity and how to monitor our patients in terms of clinical control. So I'm going to present those in a chart form. Now, I think it's difficult for me to understand or present just the charts and make it very didactic. So I'd like to start off with a case presentation of a baby, or like a 36-month-old baby that I had been following in clinic. So this is LS. He's a 36-month-old Hispanic male who came to clinic with a 3-day history of an upper respiratory illness type symptoms. And he also had the viral syndrome with it, low-grade fever, had decreased appetite. And the day prior to his consultation, mom noted that he was waking up, coughing at night. Mom was describing a whistling sound on his chest. I think it's important to note this because it's hard to diagnose wheezing unless you have a stethoscope. So this baby was probably in some sort of distress, and his ribs were sinking in when he breathes. Upon further history taking, past medical history revealed that he had been to the ED during a viral season, which is usually in the middle of the winter months. And the emergency department physician noted wheezing on physical exam. So the baby was sent home on albuterol, nebulized as needed, and a 5-day course of oral prednisolone. Since then, mom had been paying attention to his symptoms and noted that he would develop wheezing episodes even when he's not sick, prolonged cough even after his common cold had resolved. And by the way, he seems to tire very easily when and coughs easily when he runs or plays. And mom has poor recall, but she thinks she may have had another course of oral steroids in the winter. So what other questions should we be asking this mom? So I think prior to any guidelines that we were given, this would be intuitive to make, but now we are able to use a very formal sort of chart that allows us to make this classification for this baby. So the 2 domains that the expert panel guidelines gives us are the impairment domain and the risk domain. So when the patient comes in, presents to clinic, the caveat here is that the patient is not on any controller. we look at the chart that corresponds to his age group, and these would be specific questions in his review of systems that we should be asking. Symptoms including shortness of breath, recurring cough, chest tightness, any history of wheezing. Nighttime awakening is a significant component of impairment. Sometimes I also ask if, even if the child doesn't wake up, if the parents are woken up by the baby or the toddler's own coughing. The frequency of use of quick relief medications such as short-acting beta agonists, apart from that used for prophylaxis for exercise-induced bronchospasm, is also an important component of impairment. And lastly, interference with normal activity. So these would be guideline questions for us to address with the family when they come in for their initial visit. So let's go back to LS and ask more questions based on what the guidelines is suggesting for us to do. So LS coughs when he laughs in place. Laughing, crying would be the form of physical exertion for the little babies, because they're probably not running yet, they're not in sports yet. So any activity that would cause them to have a forceful breath would be one way to gauge if there's a trigger at home. LS has been needing his albuterol nebulized approximately twice a week. However, he sleeps through the night when he's not sick, although mom did remember that they would wake up with his coughing, and it wakes them up, not the baby. Interestingly, he has trouble keeping up with his peers when they are in the school playground. And mom does recall being given a clear syrup when they were at an urgent care clinic when their pediatrician's office was closed during the July 4th holiday. So this is another, I guess, classic example of, in the history taking, a lot of patients end up with either an oral bronchodilator like albuterol that could be misconstrued or misstated as a steroid. So a good history would establish whether the child actually had a third course of oral steroids in the last 6 months, or a second course of oral steroids in the last 6 months between winter and the summer. So we go back to the chart that I presented earlier, and this is sort of like an algorithmic way to approach LS. His mom said that they use albuterol more than twice a week, but not daily, although he doesn't wake up at night coughing, so I'm putting him under 0. They do use his short-acting beta agonist, his albuterol or salbutamol, more than twice a week, but not daily. And he has some minor limitation with running with his peers at the playground. Based on his history, it looks like that he's had 2 courses of oral steroids in the past 6 months. So I'm putting him under this risk for exacerbation under mild persistent. And based on the guidelines, he would qualify for initiation of therapy starting with step 2. So this is the stepwise approach that the expert panel guidelines have put up in a very intuitive, user-friendly form. So when LS started off and presented to clinic, he would fall under the step 2 management. The preferred medication for him would be low-dose inhaled corticosteroids. In the States, the safety profile and studies for children have mainly included budesonide and fluticasone. So since they have a nebulizer at home, I think LS would be a candidate for nebulized budesonide, which has also been well studied in terms of a safety profile and efficacy for babies and children. The alternative would be to use a leukotriene receptor antagonist, which is currently the only medication of that class is Montelukast. It's approved for children up to 12 months of age. However, I tend to use inhaled steroids if the child has had persistent history and repeated use of oral steroids. I gravitate towards Montelukast if the patient has no history or risk factors for allergies. So what did I end up doing for LS? I sent him home with another course of oral steroids because of his acute respiratory distress. I started him on budesonide once daily and instructed mom to brush his teeth to decrease the oral deposition of the steroids in the mouth and in the throat. We came up with an action plan to use a short-acting beta agonist, examples of which would be albuterol, salbutamol, or levalbuterol, nebulized every 4 to 6 hours as needed. Now, the recommendation to use short-acting beta agonist no more frequently than every 4 hours is sort of a built-in catch for the parents. If the baby is needing or the child is needing to use albuterol for relief more frequently than 4 hours, then it's probably time to bring the baby in for a medical evaluation and not be treated at home. Since he's at that gray area where he may not be able to use an inhaler and a spacer, it would also be a good time to discuss training the family on proper technique to use an inhaler and spacer device so they could leave an inhaler with albuterol or levalbuterol in school. Now, I will be discussing this more later, but there's also the discussion if the child is a candidate for allergy testing for inhalant air allergens. So at follow-up, usually when we start a patient on a new intervention, especially an inhaled corticosteroid, I like to see the patient back for follow-up in 4 weeks, but the NAEP guidelines recommends anywhere between 2 to 6 weeks of follow-up. So at that visit, mom reports that his cough had resolved and did not need to go see his primary doctor or go to the ED for worsening symptoms. After 2 or 3 days of oral steroids, the patient and the parents were able to sleep through the night and did not require any more albuterol for rescue. They enrolled him in kiddie gymnastics, and he has been participating without coughing or shortness of breath. There's one mom's chief complaint for this visit, however, was that the baby, or LS, was suffering from whitish plaques at the roof of his mouth and inside the buccal area of his cheeks, similar to cotton mouth when he was a baby. So clearly this is one of the side effects that we would be looking out for when any patient is on inhaled steroids. So the next component for the guidelines is the control domain. And this would be when LS comes back for follow-up. So this chart is actually summarizing questions we would ask the families in terms of a response to intervention. And it also gives us guidelines to be vigilant about medication side effects whenever our patients come for a visit. So I included this in our slide set so everybody has access to the summary charts that were published as part of this document. So when he came back for his follow-up in 8 weeks, I decided to step down his budesonide or lower the dose as recommended by the NAP guidelines to half of his budesonide dose once daily. I ended up treating his oral thrush and reinforced teaching mom how to rinse his mouth and brush his teeth every time they use their inhaled corticosteroids. We also came up with an asthma action plan and a school plan. Since he's not old enough to use a spacer device yet, I I think we just used that time during the visit to train the baby on how to breathe in and out of a tube or a spacer device for future use. And he was also scheduled for allergy testing to address other comorbidities such as allergic rhinitis. And it also will allow me to identify any possible environmental triggers at home and maybe educate the family on control measures that they can start. Now, I'm not going through the rest of the charts, but the guidelines do break down the severity and control to the 5 to 11 age group and over 12 age group. The difference between this and the 0 to 4 age group is that at age 5, we assume that most children are able to do a spirometry and lung function test. I think Dr. Dairit will be able to respond to this, but a lot of pediatricians and specialists who take care of pediatric asthma patients find FEV1 over FEC a significant component of their testing. So this was included here, although I don't think it's as important for adults. Again, there's a component of control for 5 to 11 age group. So this is here for your reference and for you to keep handy for clinic. Now, this is a stepwise approach for children 5 to 11 years of age. At this age group, there's an introduction of long-acting beta agonist. So this would be formoterol or salmeterol. This is approved for kids in this age group, so it was added on as part of the stepwise management. I circled nadocromil because this is one of the medications that is no longer available in the market. Again, this is just for your reference, and in the interest of time, I will just quickly go over these charts. Cromolyn, which is part of the 0 to 4 age group, is also no longer marketed. So this is another modification that the guidelines might change in the next publication. So this is a summary of the 12 and above age group. So 12-year-old children are considered or treated like adults. And this chart just summarizes the normal decay of pulmonary function results as we age. So this chart is pretty much identical to the 5 to 11 age group. I will skip through that. And this is the summary chart for the stepwise approach for patients above 12 into adulthood. So the NAEPP work group has met a few times during 2015, and the work group published their recommendations for updating the guidelines after 2015. There were 6 suggested updates, and I will be discussing at length 4 specific ones that are pertinent and actually clinically useful. And so this is the 6 updates that I wanted to present. Number 1 is pretty self-explanatory. They're discussing whether the medications are could be adjustable in patients who only have recurrent wheezing and not persistent symptoms. I will focus on the addition of long-acting antimuscarinic agents in asthma management, role of fractional exhaled nitric oxide, remediation of indoor allergen, specifically house dust mite, and role of immunotherapy. Bronchial thermoplasty is beyond the scope of my expertise as an allergist, but maybe Dr. Dairit can address that at a later time. So the expert panel, or the NAEPP3 guidelines, were very consistent with their recommendations. At least for patients with persistent asthma, these patients should be evaluated for potential role of allergens and are candidates for allergy testing. Asthma patients who are sensitized have increased asthma symptoms that eventually precipitate recurrent asthma exacerbations. In the US, a majority of asthma cases could be attributable to allergy and allergic triggers. And over 80% of school-age children have at least one sensitization to a common air allergen. There are studies, and I included the references here, that there's a positive correlation between the number of positive skin test results with asthma severity. So the more allergic you are, the more likely you are to have moderate to severe persistent asthma. There are a few important household mites. Bologna tropicalis is probably more predominant in the Philippines, but there's a bit of homology and overlap between these species. But we test them separately because each species could still trigger its own unique epitope. Dust mites, house dust mites usually live in bedding. They feed on dead, shed human skin, and they usually survive in low altitudes and relatively high relative humidity of 50 to 70%. So the evidence has shown that there is a causal relationship. So this is not just an association, it's not just a suggestion. The studies have shown that there is a causal relationship between indoor biological and indoor chemical pollutants and asthma. So the first line recommended for reducing exposures would be to use plastic casings for the mattresses and pillows. So this should be allergen proof. I think these are available in Shoe Mart. Washing the bed linens once a week in hot water. Sorry for the plug. Avoid using down fillings for your pillows and duvets. Throw away stuffed animals, especially those that you can't wash. This might be, the last recommendation might be difficult to do. Reducing relative humidity might be difficult to do, but in the States you could purchase a dehumidifier. I'm just not sure how efficient that is. The second line would be using acaricides and tannic acid, using high efficiency particle arrestants, vacuum cleaner bags to prevent aerosolized house dust mite fecal material from being airborne. So since these are heavy particles, they usually settle on the ground after it's been stirred up in the air. So that's the reason why air filters or of any kind are unlikely to be useful or helpful, because house dust mite particles usually settle on the carpet soon after it's been stirred up by vacuuming. This is just a quick review of the correlation between dust mite allergen sensitization and asthma morbidity. This is a double-blind, placebo-controlled, randomized controlled trial of 52 school-age children, and it showed a significant reduction in between reducing house dust mite exposure and dosing for inhaled corticosteroid group in the intervention group versus the asthma patients who did not have any house dust mite mitigation treatment. This is also just a quick glance on previous history of previous studies that have shown correlation between the development of asthma in children if they have a previous sensitization to dust mite. And this is the same phenomenon is observed in adults. Now let's, I'm going to change gears and talk about another aspect of the NAP guidelines, talking about adding long-acting anticholinergic agents in the management of asthma as an add-on to inhaled corticosteroids and LABA. So previously there have been small proof of concept studies, but 3 or 4 other studies have been published since 2007. However, by far the biggest study is Kirsten's. It was published in the New England Journal of Medicine in 2012, where he showed in 2 replicate studies, randomized placebo-controlled trial, the efficaciousness of tiotropium compared to placebo. So they enrolled 912 patients between the ages of 18 to 75. The exclusion criteria would be smoking. And these patients have had a 5-year history of asthma, not well controlled on inhaled corticosteroids and long-acting beta agonists. So these are patients who are already on step 5 to step 6 therapy. They've continued to have FEV1s less than or equal to 80% predicted, and a history of 1 serious exacerbation in the past year. So one arm received tiotropium 5 micrograms per day using a soft mist inhalation or Respimat, and the other arm received placebo. And these patients were followed for 48 weeks. So the previous studies have actually been much smaller cohort, or the sample, I think the biggest one was 50. So this is the biggest population so far. And the previous studies have also been a lot shorter. So this is the longest and biggest study looking at LAMAs in asthma management. There were 2 primary outcomes that they looked at. At 24 weeks, the tiotropium arm showed a significant improvement in the peak FEV1 compared to baseline, compared to the placebo group. And this was replicated in both trials and with very significantly different results. The other outcome that they looked at was the pre-dose or trough FEV1 for the patient. So tiotropium is dosed at once daily, so it's an ultra long-acting antimuscarinic agent. So the next dose, you should expect some waning of its effect. However, they did not demonstrate that in this study. And in fact, the pre-dose FEV1 remained improved compared to the placebo with a very significant difference. One of the secondary outcomes that they looked at was time to first exacerbation, and tiotropium was superior to placebo in overall reduction of risk to severe exacerbation compared to the placebo arm. So I've included the link here for the reference, so you could access the study in more detail. The FDA has approved at the current time 3 drugs, 3 long-acting antimuscarinic drugs, one of which is a shorter half-life, and it's dosed twice a day, aclidinium bromide. The other 2, glycopyridine bromide and tiotropium bromide, are given once daily. So LAMAs is actually like a magic drug, and so it's been studied quite well, and I've included one of the exhaustive reviews as a reference here. It has multiple roles, and it can serve, it has anti-inflammatory function by inhibiting recruitment of eosinophils, which is the culprit in airway inflammation and airway remodeling. LAMAs do this by inhibiting cytokine production, namely decreasing IL-4, IL-5, and IL-13. So these are important cytokines in the recruitment of eosinophils in the airway. They've also found that it inhibits chemotaxis in monocytes, neutrophils, and macrophages. It decreases mucus secretion by decreasing or blunting mucus gland hypertrophy. So there's less mucus production, which is another pathophysiology that causes significant symptoms in asthma patients. And lastly, they've shown in animal and human subjects that it inhibits smooth muscle thickening and airway remodeling, which again is an important component of asthma pathophysiology long term. So I've taken the liberty of putting LAMA here where I'm thinking that it's going to be added on in the stepwise approach of managing asthma in patients older than 12, because it's not been approved for use in younger children. For the third addition to the updates, I'd like to discuss the role of fractional exhaled nitric oxide, or FeNO. So there's a lot of excitement that's been generated by the discovery of nitric oxide. So in 1987, Ignarro and Palmer described a nitric oxide free radical, and they figured out that it was actually the endothelium-derived relaxing factor. So they were calling this molecule endothelium-derived relaxing factor, but nobody knew what it was, and then they realized that it was, in fact, nitric oxide. So since then, there's been a burgeoning amount of scientific data that shows that nitric oxide is involved in multiple physiologic functions of our body, including neurotransmission, immune function. It modulates vascular tone, cardiac contractility. As well, it could be an important marker for carcinogenesis, ischemia, reperfusion, hypertension, including pulmonary hypertension and septic shock. Now, for physicians and healthcare providers who take care of patients with asthma, its role in the lungs and in the airways is actually crucial and quite exciting. Sorry for being excited about FeNO. So it's an important bronchodilator, vasodilator, and a non-adrenergic, non-cholinergic neurotransmitter. So it also is a very important modulator of the inflammatory response. So everybody was so excited about FeNO that it was named Molecule of the Year in 1992. Parang class 90. So I included the reference here in case you would like to read this in greater detail. But FeNO is sort of like the breakout star in asthma management. So briefly, in the airways, it's produced by the breakdown of L-arginine to L-citrulline, and this chemical process is catalyzed by inducible nitric oxide synthase. So INOS is the predominant isoform of nitric oxide synthase in the airway epithelium. It is expressed by T lymphocytes and macrophages, and there's a clue to its presence that the production of nitric oxide has a bronchoprotective effect, and thereby preventing smooth muscle proliferation. So the production of INOS and this breakdown to citrulline and producing nitric oxide is induced by different types of cytokines, namely tumor necrosis factor alpha, interferon gamma, IL-1 beta, and bacterial produced endotoxins, giving us a clue that this is an important defense mechanism of the airway epithelium against pathogens. The common measured way or method for measuring FeNO is via chemiluminescence or electrochemical cell technique, and it's reported in units as parts per billion. So recently, well, 2003, the FDA approved the desktop nitric oxide monitor, and last year or 2 years ago, the European Respiratory Society and the American Thoracic Society came up with guidelines on the use of FeNO and how it's applicable to the clinical practice. FeNO is important because it's a surrogate marker of airway eosinophilic inflammation. So it's usually elevated, and it differentiates different respiratory processes. It's elevated in allergic asthma, bronchiectasis, allergic rhinitis, and eosinophilic bronchitis. So it can become an important biomarker of disease severity when we see our patients in clinic. And more importantly, it can clue us in whether that patient will be responsive to steroids. So again, I've included two different references here for your, if you would like to read about FeNO in greater detail. So in 2011, the American Thoracic Society published a working document on how we as clinicians can use the FeNO monitor, starting with the diagnosis of asthma. And I quote the document as saying, high FeNO, so the cutoff point for adults would be greater than or equal to 50 parts per billion. And in children, FeNO is naturally high, so there's a lower cutoff for exhaled nitric oxide in children, and the cutoff is at 35. The presence of high fractional exhaled nitric oxide is likely to indicate significant airway eosinophilia, and therefore these patients may be steroid responsive, mainly because eosinophils are very, very responsive to steroids. Now, it's also useful in monitoring the treatment response. So let's say the patient comes back for follow-up and the patient has been started on inhaled corticosteroids. These are a few possible reasons why the exhaled nitric oxide would persist to be elevated. There could be allergen exposure, poor adherence, poor inhaler technique. So this will allow the clinician to address this with the patient at point of care. So my last discussion will be the role of immunotherapy in the treatment of asthma. In a Cochrane review of 75 studies, including about 3,500 participants, most of whom have asthma, they were able to show that there's a significant reduction in asthma symptoms and improvement in bronchial hyperresponsiveness and medication use after patients have been started on an allergen immunotherapy. So this is just one of those studies, one of those reviews, but there's a lot, a plethora of these studies published that shows that immunotherapy is indeed useful and helpful for patients with asthma. Briefly, patients on immunotherapy have shown these immunologic markers. So there is some physiologic changes in the immune response to allergen exposure. After immunotherapy, there is reduction in specific IgE or allergen-specific IgE. There's increase in specific IgG4, which is a subclass of IgG that is a marker for immune tolerance. There is a shift in the Th2 predominant cells. So the cytokine IL-4 is downregulated. So there's a shift from Th2 to Th1 predominant cells in the body, the blood, in the lungs, in the skin. And this is driven by the increased production of IL-10, TGF-beta, and interferon gamma, which are pro-inflammatory cytokines, as opposed to Th2 cytokines, which are more driving the cells to produce allergies. And lastly, immunotherapy results in increased T regulatory cells, which again mediates immune tolerance to allergen exposure. So this is my last slide. I just wanted to give a shout out to the importance of using spacers. This is an example of a spacer device, but there are multiple products, multiple kinds of spacers. And the role of spacers is really to decrease the velocity of the meter dose inhaler particles. So they usually are put in with a propellant, CFC-free propellant. And once it gets into this chamber, it would be easier for the patient, especially children and toddlers, to inhale at regular tidal breathing. And this prevents medications from being deposited to the oral mucosa or the posterior pharynx where it's not needed. And it also decreases absorption, especially if the patient is on inhaled corticosteroids with a high first pass metabolism. So it decreases exogenous absorption of these inhaled steroids, especially for the young kids who will be whose growth can be affected by exogenous steroid use. I included the link for the fact sheet for how to use an inhaler and a spacer device. And in the interest of time, I would encourage you to go to this site and review it or print it out and give it to your patients. Thank you for your attention.
Okay, thank you for the insightful lecture, Dr. Mesis. And we also would like to thank our sponsors for this webinar, AstraZeneca and Getz Pharma. We'd like now to introduce our reactor, also one of our classmates, Dr. Francis David, who earned his medicine degree at the University of the Philippines, Manila, and after finishing a rotating internship at the UP PGH in Manila, he completed an internal medicine internship and residency at Beth Israel Medical Center, New York. He then followed this training with a critical care and pulmonary fellowship there. A fellow of the American College of Chest Physicians, Dr. David is the director for the Pulmonary Rehabilitation Program at Lexington Medical Center. May we now call on Francis, our classmate, Dr. David.
Can you hear me? Good evening.
Can you ask to repeat the
Francis, we're not getting your audio.
Your audio.
There, can you hear me?
Yeah, can you do it again? We didn't catch anything.
Start from the
Yeah.
Okay, thanks. Again, thank you for inviting me to participate in this. It's nice to see my classmates over the internet. As mentioned, asthma is one of those diseases that I've been quite interested in my pulmonary career. Actually, it's very interesting how over the years the treatment for asthma has changed significantly. But you know, with all the new changes with asthma medications, I think going back to basics is still a very useful and how would you call it? It's a very useful and fruitful endeavor. So basically, as Grace had mentioned, the use of the guidelines for stepwise therapy is very important because determining where you are in terms of the disease process will determine the proper treatment that you will provide. So evaluation is very important. And really, if going through the guidelines, you really don't need any important, well, you don't need any advanced machines. All you really need is to get a decent history, a good stethoscope, and if you have a spirometer, well, at least a spirometer and a peak flow meter, you should be able to provide a very decent therapy to 90% of people. I also agree with Grace in terms of the use of a spacer. I think I would expand that to say that depending on the situation where you are, not only is it the technique that's important, I guess it's the method of delivery for inhalers that would be also very important. I guess creativity also can come into play in certain situations. I remember that when we were doctors in Sorsogon many eons ago, we tried to make our own spacers using soda bottles. You know, you can be creative with using everyday materials so that you can improve the delivery of the medications that are in inhalers. Because as a standalone inhaler is really a very poor delivery device, and a spacer will improve the delivery of the medications by about 50 to 60% if done properly. Grace had asked me about the use of spirometry as a measure for lung function. I don't do any pediatric, in terms of the pediatric population, I do not do too much test. Well, I don't do testing for pediatrics. Most of my experience is really in adults. But in terms of spirometry, I think spirometry is a very useful tool. It's actually a very useful tool for both determining the presence of reversible airway disease and for identification of people with beginning obstructive disease. So basically, as Grace had mentioned, the FEV1 to FVC ratio is the parameter that they use for children. We also use that in adults, but the value that we use is lower. But the use of the spirometer, the use of spirometry for identifying people with possible airway disease is, I think, the minimum that you should have in terms of so that you can really identify these people. The other caveat that I would add is, if you are able to, how would you say it? If you are in an institution that does have more advanced equipment, I was wondering how effective, and I'm posing this question to Grace, if they have any information about the use of plethysmography, where you are using plethysmography to measure airway resistance and conductance and specific conductance to identify patients. Because specifically in my experience, I think the maneuvers for plethysmography is less dependent on effort as compared to spirometry. So that's just a caveat. But then, you know, that to be able to do plethysmography, you have to have a body box.
Yeah,
go ahead.
Well, to that point, we were able to use the body box plethysmography during fellowship. So it was at a tertiary center at a big city. It was a referral center, but and again in Virginia. So I think even if it's a useful tool or an important tool, access to a body box apparatus would be a very crucial issue. So you still would probably have to refer the patients to a bigger hospital center where a pulmonologist would be able to interpret the results. And it has limited use in children.
Oh, yeah, because that was my question. Because my experience with, and this is more my experience and with talking to respiratory therapists, in doing the maneuvers for plethysmography, it's less effort dependent. So I don't know if there are studies to show that at least in the pediatric population, because in adults sometimes since we have plethysmography, I would refer and sometimes depend more on the plethysmography compared
Then spirometry.
to spirometry, especially if effort was in question. So it's just, you know.
Yeah, I don't know about that. I think it's more accessible for me because you could have an office spirometer, and so you use that at
Right.
point of care
Right.
versus having to schedule a patient for body box plethysmography at the tertiary hospital. So, yeah, but I see your point.
Yeah, in terms that's
Um,
type of device that you're going to use to deliver the medication will be essential because you have to match it up with the patient, and I think it's just another type of it's one more tool in your toolbox that you can use, especially for people who, well, some people just prefer inhalers, some people prefer dry powder inhalers.
or those who don't want to carry a spacer device.
Right, exactly. So I think they're using the proper technique. There's no significant difference among them. I think it might really boil down to sometimes it will boil down to the molecule, especially if you're talking about long-acting steroids and the LAMAs. So again, it's a combination of the molecule itself that you're using and the delivery system and how that delivery system interacts with your patient. So especially in kids, that will be more important too. You know, in kids, you have dry powder inhalers, you have MDIs, meter dose inhalers, and you have a nebulizer.
So they can know.
So again, just match it up with the patient.
Okay. Thanks,
the other
Francis.
thing, yeah.
Oh.
Yeah, because I was going to mention the thermoplasty that you were asking me about.
Yeah, I didn't address that because I.
Yeah, in terms of bronchial thermoplasty, as a clinician here, we've been looking at that. I don't know if people are aware of what bronchial thermoplasty is. It's basically what it does is just as a preview. The theory behind it is what you use heat in the form of microwave, and you deliver the heat through probes in the airway using bronchoscopy. So basically, you do a bronchoscopic procedure. Well, actually, it's a series of 3 bronchoscopic procedures, doing one lobe, lower lobe, and then the 2 upper lobes in 3 different procedures. And the goal first of all, the patients that you do this in are patients who are, as of now, we were reviewing the data. I don't think the data is really out there that it is that effective. I think they've determined that it's safe. It hasn't really caused too many problems. But in terms of, I think the longest data that's available is about 5 or 6 years on people who had it done and they haven't seen any complications in them. But then in terms of the outcomes, I think the jury is still out. But basically the goal in doing bronchial thermoplasty is trying to reduce the muscle mass in the airways and to try to reduce the deposition of collagen in the airway. So just as a primer, you might be hearing more about bronchial thermoplasty, but I don't know how successful it's going to be. It's still one of those things that are up in the air. And then I guess the other things that I would mention is, you mentioned the use of leukotrienes, which, since we graduated from med school, back then our only medications were albuterol and steroid. Yeah, and theophylline. And basically, if you look at it, now you have omalizumab, which is an IgE blocker. Last month, they approved mepolizumab, which is the
IL-5.
Yeah, eosinophil. Yeah. So for IL-5.
Yeah.
And so between that, leukotriene blockers, steroids, I still use theophylline from time to time. The use of ipratropium bromide or the long-acting or the LAMAs. We've had a good amount of new medications that we can use, and depending on the medications that are available, I think we've come a long way since the days of theophylline and steroids, and I think each one has its proper use. Like I said, theophylline, what is it? You should know that. You might know this better than I do. It's theophylline is cyclic GMP and
inhibitor. Yeah.
Yeah, it decreases.
It has a lot of side effects.
The other one is cyclic AMP. Well, the muscarinics increase your cyclic AMP, so you have bronchodilation, and then theophylline is, or is that the other way around? And theophylline is the reducing cyclic GMP. Basically, they basically increase your bronchodilation. So we just have a lot more medications that are available now that we can use. And I guess I won't be my father's son if I don't mention. Actually, as I was listening to you, I looked up MCT oil and asthma. There's actually an interesting paper that showed that the use of MCT oil reduces your preponderance of developing allergies to peanuts, which was, they were saying that it had to do with the way the antigen was delivered to Th2. Which was, I said, oh, that's
okay.
So that's something you can do back home. Use your coconuts.
Thanks, Francis. I think I want to address one more question from Dr. Jonas Bernal. So Jonas, thank you for asking this question about when does airway remodeling start? So this is actually a very difficult question to answer because unless you do a lung biopsy and actually examine, at the cellular level, the smooth muscles and the different layers inside the airway epithelium, you won't be able to answer that question. So because it means doing lung biopsies in babies. But in fact, there were a few studies only with a small sample size that have shown that airway remodeling can actually begin as early as 24 months of age. So there is these babies who were enrolled and studied for other reasons, and their lung biopsies have shown that airway remodeling has been well on its way by that age. So I think early intervention is another buzzword that you're hearing about in asthma management circles.
Yeah, that's a very interesting question. At least for the pediatric population, I don't know how you can tell because you can't do any studies. We make it by inference when you basically have fixed airway obstruction. That's when you have airway remodeling, especially based on the history that they've had asthma.